Okay. Hello, everyone. Good afternoon, morning, and evening. I think we have people joining us from different parts of the world. So, yeah, thank you for taking the time out, everybody. Um, I think we're still waiting for a couple of for a few of our panelists to join, but let's get started. And they'll. I think we have our first few speakers already, so that should be fine. Or we can just shift around if somebody's delayed for any reason. Um, yeah, couple of housekeeping, um, yeah, sort of pointers. So we have already started the live stream. So but if anybody has any, any sort of concerns, objections, please let us know right away, and we'll stop that. So I'll just give you like another 5-10 seconds to let us know. You could mention that on chat as well. If there's a point during the conversation when you would like the recording to stop, do let us know. We'll do that as well. In terms of documentation, we will put together an event report, but also we will be having preparing a transcription of the event, for which we will be using the recording as well. At that point, we will share it with we'll try to share it with all of you. Do send in your email IDs if you think we may not have them. And we'll share the transcription with you beforehand, before publication, so you could ask for anything to be tweaked in there as well. The other norms are as is. Stay on mute if you're not speaking. So and raise your hand if you'd like to speak. Use the chat for discussions, questions, comments. While we'll be taking them on at the end of the presentations. That is, after all the presentations are done. I and my colleagues will be putting them together and sort of bringing them up again at the during the discussion session. So I think that should allow us to have questions for everybody at the same time. We also had shared a code of conduct with some of you. We've not been able to do that with everybody else. We'll be pasting that in. We'll be pasting that in over in the chat as well now, and in like 15 to 20 minutes time as well, in case people join late, so they have access to that as well. But yeah, a couple of things to be mindful is that going in line with the discussions we are having today, we'd like everybody to be mindful of the space that we are in. Be thankful, at least I'm thankful for the privilege of being here, of being able to continue work through online ways in the middle of the pandemic. I want us, as always, to be mindful of our co-participants, be sensitive to the topics being discussed and the language that we use to discuss them. Yeah, I think I've covered most ground. If anything else comes up, I'll mention that on chat. Feel free to use the chat for discussions amongst participants as well. We'd like, I mean, whatever ways you're comfortable with in discussing, raising questions, up to you. With that, I think nobody has any objections to the recording happening. Yes, and we unfortunately don't have the time to go around and introduce everybody. So if you could, it would be great if you could mention like maybe an affiliation or where you are from, anything about yourself, and importantly, your pronouns as well in your display name, if you're comfortable doing that, of course. And yes, thank you, Brinda, for mentioning that too. Let us all be mindful of the pronouns that we're using. To quickly give everybody a little context into into like the motivations behind having this event, these discussions today. Oh, yeah, I'm Ayush, sorry, from the Center for Internet and Society. I've been a researcher here for a few years, and I've been doing research at the intersection of technological change, gender, and labor. Um, yeah, today's event is fairly sort of momentous to us. And it also, by the way, marks International Transgender Remembrance Day. So that was unplanned, but yeah, it's also momentous for us because it sort of marks a couple of years of very concerted research into technological systems and gender and sexuality at the organization. The two projects that we're talking the two research projects that housed the work that you'll be hearing about today. One was funded by Privacy International, which is tech rights um, and a tech rights advocacy organization based out, research and advocacy organization based out of the UK. And another project called the Big Data for Development Project, which was curated and created by IDRC, which is the sort of sovereign philanthropic organization of the Canadian government. I'd like to thank them both, not only for funding us, but also for giving us the intellectual freedom to conduct the research in ways that we thought would be best. The motivations behind this research have been to sort of center lived experiences of marginalized gender and sexual communities and individuals identifying with and as these identities. The idea has been to bring in these perspectives into a lot of change that we are seeing around us, especially in terms of how technological change is increasingly sort of taking over how welfare systems and so many other systems that we see around us are being sort of created and implemented. So one of the key things that we wanted to do is to sort of mainstream the sort of situate people's positions, people's positions, their bodies, their experiences in some of the sort of policy discussions, some of the theoretical constructs around civil rights and liberties as associated with technological changes. So key among them being, for example, the right to privacy, which fairly recently was sort of laid down as a fundamental right in India. But a key question that we have been grappling with is how can we sort of frame and understand the right to privacy by centering people's experience of what privacy means to them and how they feel that it is being encroached upon by the state and other actors. That's more on all of this during the rest of this evening. We are very grateful that we have, the event will be moderated by Radhika Radhakrishnan. She was a part of the conceptualization of the project when she was during her brief stint at CIS. And I'm glad that we're able to bring her in again at this stage to mediate some of these discussions. Thank you so much for joining us, Radhika. I'm super excited to have you here. Your research and your activism continue to inspire us. And yeah, with that, the floor is all yours.
Thanks, Ayush, for the incredibly kind introduction. I'm glad to be here too, especially because I've gone through some of the work that the panelists today are going to be presenting, and it all looks not only incredibly interesting, but I think incredibly important to discuss at this current time. So I'm not going to take much time giving an introduction. Ayush has already covered everything. I'll begin with the first panelist, but just a note to all panelists before we begin that in the interest of time, because we want to ensure that we can address some audience questions and other questions at the end of the presentations, I will just request all speakers to keep their presentations to 10 minutes, and I'll give you a reminder when you have 2 minutes left. So you could wrap up at that point if that's all right with everyone. So with that, let's actually just begin, because I think what all the panelists have to say is going to be far more interesting than any introduction I can give right now. So as our first panelist today, we have Brinda Lakshmi K, who is a non-binary queer feminist researcher and writer. They work at the intersection of human rights, identities, and technology. Brinda today will discuss their work on the impact of data and digitization on transgender persons' access to public and private services, touching upon issues such as access to ID documents, impact of data collection processes on welfare design, and misrepresentation in data, among other issues. With that, Brinda, the floor is yours, and you can begin. Brinda, you're on mute.
Thanks, Radhika. Hi, I'm Brinda. I'm a non-binary researcher working at the intersection of human rights, identities, and technology. In 2018, I did a qualitative study to understand the biases of data for development and its impact on transgender persons in India. Gendering of development data in India beyond the binary was a study undertaken for the Center for Internet and Society, India, as part of the Big Data for Development Network supported by IDRC Canada. This study looks at different development data collection initiatives in India to question the inherent assumption that large-scale data sets are the best reference points for designing development solutions, especially for marginalized groups like the transgender community. I'm going to be presenting some key observations from this study here today in an attempt to understand the impact of gender data on access to healthcare. My talk will specifically focus on transgender persons, that is, individuals who don't identify with the gender of their assigned biological sex at birth. I will delve into how both public sector development data and private sector data expose transgender persons, an already marginalized population group, to further vulnerabilities. The aim is to help you understand how both the systems fail to provide access to essential healthcare services to transgender persons in India, while also exposing them to surveillance. Although this study was conducted before the passing of the Transgender Persons Protection of Rights Act 2019, the findings presented here today will be relevant to the development data presently available on transgender persons in the country, and consequently their access to welfare and their rights. The present global development agenda is to leave no one behind. The effort to leave no one behind has shifted the focus of the government towards collecting data on different population groups. The design of and access to welfare programs relies heavily on the availability of data. This shift in focus to data has led to further exclusion of already disenfranchised groups, including the transgender community. The problem with this lies in the framing of the development discourse as one that demands data as the prerequisite to access welfare benefits, including healthcare. Digitization was now supposed to remove existing offline challenges and enable more citizen-centric systems for inclusion of all. However, digital systems seem to have replicated the existing offline challenges and in several cases added to the complexities involved. Now, nationally issued IDs have become necessary to enter these data systems in order to access government welfare and government subsidized services, including healthcare. So, due to their gender identity, transgender persons face different sets of challenges in procuring valid identification documents and then entering these data systems to be able to access healthcare. So there is firstly, primarily to begin with, an access challenge for transgender persons with respect to healthcare. These challenges include, but not limited to, lack of standardized online or offline processes to aid in changing their documents. And this process varies across each state and with respect to different documents. Procuring any identification document in preferred name and gender requires existing identification documents in given name and assigned gender in both online and offline systems and processes. However, due to the stigma with their gender identity, often transgender people run away from home without an ID document in their assigned name and gender. When you're running for your life to save yourself, you're not considering these things. Then, so with or without an ID document, in any case, individuals have to go through a tedious offline process to change legal process, sorry, not offline legal process to change their name and gender on different documents. Now, information on such processes, digital or otherwise, are usually available only to individuals who are either educated or associated with a non-profit organization working with the community. The challenges are far higher for individuals with neither. Now, the newly passed law is supposed to address these challenges. However, even with the passing of the new law, unless the systemic issues are uniformly changed and sensitization is adopted uniformly across, all these data challenges are most likely to continue. So similar to the challenges that I mentioned for transgender persons, the need for data poses similar vulnerabilities for the entire spectrum of the gender and sexual minorities, and the different categories, including like cis women, LGBTIQA plus persons living with HIV and sex workers. Many of these different population groups will be covered by the other speakers. So now, with respect to the challenges that transgender persons face, these challenges have prevented transgender persons from accessing public healthcare systems due to the lack of a valid identity document. Even those with ID documents face other challenges like stigma and discrimination due to their gender identity. Not all service providers, especially in the private sector, have transgender as a gender category. So even with a valid ID, they may not be able to access services like not just healthcare, but banking, especially access to healthcare, insurance, sex reassignment surgery, a life-affirming, gender-affirming surgery is considered to be a cosmetic surgery by many insurance providers and hence not under insurance coverage. So this shows that systems have not been designed for inclusion of transgender persons, even once they have entered these systems with a valid ID document. There are not services available which are there to cater to them as such. And additionally, they also face privacy challenges due to the marginalization of their gender identity. And as mentioned earlier, India presently does not have a privacy law, although it's been recognized as a fundamental right. So along with the general surveillance by the state, now with all our IDs likely to be linked, there is a fundamental concern with respect to security of information shared with public and private health service providers for transgender persons, and the threat of such information being disclosed to people known to them, known to the concerned transgender person, and that causing physical and psychological insecurity, especially when they're not out to their family members or anyone else. And then there's also mandating of Aadhaar for accessing life-saving drugs like antiretroviral therapy, which has seen patients stopping their medication due to worry of disclosure of their HIV status to their family and other people known to them, because there is heavy stigma around being HIV positive. Now, the system as such was basically created to include people, but as you can see, it has resulted in people dropping off the system instead of actually being part of it because of the surveillance security concerns. Further, there is also apprehension from the community about using the digital footprint of people along with official statistics to monitor healthcare and to deliver development services, because it will expose them to further surveillance. We've seen.
Sorry, you have 2 minutes left. Just wanted to give a heads up.
So we've seen instances of these sort of happening with people who have been discharged from after being discharged from the hospital with being COVID positive as well, service providers reaching out to them. So there's a definite concern with respect to data breach already that we're seeing as well. And irrespective of gender, over the years, there have been several data breaches that we have seen, instances of data breaches, right? So in December 2016, 43,203 HIV patients data was publicly available. In late 2019, again, another million people's medical studies were publicly available. So here the important thing is, as much as it is a concern for everyone, here the important thing to understand is the impact of such a breach of data on individuals of an already marginalized identity compared to others from a more privileged identity, right? Simply put, the present system expects individuals to turn themselves into data in order to access their rights, and the inability to do so means exclusion, especially for transgender persons. However, turning themselves into data with identity documents also does not guarantee access to rights and also exposes them to surveillance. Then the global inclusion agenda of leave no one behind becomes definitely questionable. The present situation for transgender persons is to choose between access to welfare, healthcare included, and privacy, right? Although both are supposed to be fundamental rights. Somehow being already marginalized seems to make it fair to ask them to pick between the two. So with that, I'd like to conclude building on the words and work of Dr. Usha Ramanathan. With data as the primary focus, systems that tag, track, and profile transgender persons, placing them under surveillance, have consequences beyond the denial of services and enter into the arena of criminalizing for being beyond the binary. The vulnerabilities of their gender identity exacerbates the threat to freedom. With their freedom threatened, expecting people to be true about their identity just to get access to what they were promised by the state goes against the very idea of development and human rights. Thank you.
Thank you so much, Brinda, for your presentation and for also keeping it to the time. Interesting that this was something that you said was carried out before the Trans Act got passed. And just listening to a lot of the findings that you were sharing, very saddening that neither is this actually, something that can be improved through the Trans Act, but looks like the situation actually gets a lot worse with the legislation. So one avenue that one would expect for recourse for injustices itself is quite cut out in this sense as of now. So thank you so much for bringing this to light and for sharing your findings with us. And I think Ayush has also shared a link to the work on chat for those who are interested. I can also see there are a few questions here, so we'll be taking all the questions in the end, but please feel free to keep dropping in questions on the chat as you think of them, and then we'll queue them up in the end on our discussion. So with that, I would like to invite the next panelist, who is Shreya Anusuya, who is a writer, editor, journalist, and performance artist based in Calcutta. Shreya will be in conversation with J.D. Sarkar and Aryan Somaiya on their experiences of accessing sexual and reproductive health services, including barriers such as stigma and erasure of gender identity. J.D. Sarkar is a self-employed trans man, and Aryan Somaiya is a trainer, author, and activist on gender and sexuality. Shreya had interviewed them and other members of the community for her work on barriers to access to SRH, sexual rights and reproductive health. So with that, I invite Shreya to take over the floor and present.
Thank you very much, and thank you for your excellent presentation, Brinda. I hope I am audible.
Yeah.
Yeah, okay. All right. I am going to be as brief as I possibly can. I'm going to quickly present some of the things that emerged in the conversations I had with 6 transgender men in states in India. In addition to which, I'd also interviewed two intersex folks and two people on the asexuality spectrum. But given that we have a limited amount of time today, I'm going to be only focusing on my interviews with trans men and their access to sexual and reproductive healthcare in particular, and healthcare in general, really. I found that each of the trans men I interviewed had experienced gender policing and surveillance, making it difficult for them to access healthcare that they could truly trust. One of these forms of surveillance was gender segregation and policing from other patients, but also from healthcare professionals. And this surveillance as well as policing included discriminatory and bigoted behavior, including misgendering, calling them by the dead name, interrogation about gender identity, staring, mocking, and other kinds of verbal and other kinds of abuse. And gender segregated spaces at private as well as public clinics contributed to this policing and surveillance. For example, one of the interviewees reported feeling extremely uncomfortable in the queues outside of clinics because they were within the gender binary. And no matter which queue they stood in, they were continuously harassed by other patients. And another person said that they were put in the women's ward where he was naturally very uncomfortable. And this wasn't restricted to patients, but also healthcare professionals made discriminatory comments and sometimes outright denied care. In 2 instances, trans men were asked to get parents along or get permission from parents, even though this is patently unconstitutional and unethical, given that the self-identification of gender identity is something that's mandated by the Supreme Court. So no such permission should be required, but this was asked for in 2 different instances. There's also a huge gap in access to health-related information, and healthcare providers are not doing enough to give this information freely to trans men. The trans men that I spoke to relied heavily on community support and or looked up things on their own because they were not getting the information that they were asking for. And when information is sought, instead what they found was they were getting intrusive questions in return. And then the medicalization of the discourse is also an issue. I'm going to quickly wrap up because I see that I'm running out of time and I want to give JD and Aryan more time than I have to speak. But just to end with 2 points. One is that because of a host of discriminatory experiences, trans men are actually reluctant to access healthcare, even when they are extremely unwell, because they can't be sure that they will receive sensitive and affirmative healthcare. And almost everyone I spoke to had found a doctor via a trusted source in the community. And also what is considered life-saving and essential is extremely different. If you look at it from the healthcare professionals' perspective, they don't think of, say, gender affirmative processes and procedures as life-saving or essential, which heavily impacts access to really incredibly important healthcare. So with that, I would like to invite JD, please, to share your experiences. I'm going to speak to JD in Hindi. How should I do this, Radhika? Should I type a translation in English? Because I'm aware that not everyone would be comfortable with Hindi.
So I can also do a quick translation at the end if you want, or you could also translate it later. Either works.
So I'm happy to translate, but should I type it or should I speak it? What's more accessible? I
think it's better if you speak it after maybe after the entire thing, a summary or whatever you feel is best.
All right. Okay. All right. Hi, JD.
Hi.
Hi, how are you? Thank you so much for joining us. JD, if you could please share about your experience.
One second.
Sure.
Yeah. Hi.
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 তুমি শুনতে পাচ্ছো?
হ্যাঁ শুনতে পাচ্ছি।
হ্যাঁ, ওকে। জেডি, আমি কি হিন্দিতে বলবো না বাংলাতে?
যেটাতে কমফোর্টেবল হয়।
I'm just going to use বেঙ্গলি। তো যেডি আমরা একটা কথা যখন ইন্টারভিউ করেছিলাম, আমরা একটা ক্লিনিকে নিয়ে কথা বলেছিলাম, যেখানে তুমি বলেছিলে যে ক্লিনিকে একেবারে প্রাইভেসি পাওয়াটা খুবই মুশকিল ছিল, আর সবাইদের সামনে তোমার কথাগুলোটা তোমাকে বলতে হচ্ছিল। আর তুমি যখন প্রাইভেসি রিকোয়েস্ট করেছিলে আর বেশি টাইম রিকোয়েস্ট করেছিলে, তোমাকে ডক্টর সেটা বলতে দিল না। সেটার ব্যাপারে কি আজকে শেয়ার করতে পারবে?
আমি কি ভিডিওটা অন করে নিতে পারি?
তোমার তুমি যদি কমফোর্টেবল থাকো ভিডিওটা অন করতে পারো, না হলে অফ, যেটা তো অ্যাবসলিউটলি আপ টু ইউ, তোমার প্রেফারেন্সের উপর।
আচ্ছা।
হুম।
হাই।
হাই।
কেমন আছো? ভালো আছো?
ভালো আছি। আমাদের আসলে তাড়াতাড়ি শেষ করতে হবে, তো তুমি কি কোয়েশ্চেনটা শুনতে পেরেছিলে?
হ্যাঁ হ্যাঁ, শুনতে পেয়েছি।
হ্যাঁ, তুমি কি কমফোর্টেবল আছো এটা শেয়ার করার জন্য? আদারওয়াইজ আমরা
অবশ্যই, হ্যাঁ হ্যাঁ, আমি শেয়ার করছি। ব্যাপারটা হচ্ছে, আমরা যখন কোনো ডাক্তারের কাছে ভিজিট করি, তখন সেই ডক্টর অ্যাকচুয়ালি মানে কমফোর্টেবল থাকে না আমাদের সাথে, মানে ডিরেক্টলি কোনো পেশেন্টদের সাথে সামনে কথা বলার জন্য। ইভেন কি সেই পেশেন্টরা আমাদের দিকে উল্টো পাল্টা ভাবে তাকিয়ে থাকে, মানে কিরকম ভাবে কথা বলে, মানে সাইডে টোন করে, মানে অনেক রকমের হ্যারাসমেন্ট আমাদের ফিল করতে হয়। দেন ডক্টরও অনেক সময় মানে আমাদের হেজিটেট ফিল করে, মানে ডক্টরও পর্যন্ত আমাদেরকে মানে দেখে কিরকম একটা বিহেভিয়ার করে, মানে ওখানে অন্য পেশেন্টদের দেখছে। অ্যাকচুয়ালি মেনলি আমাদের কলকাতাতে আমরা যখন ডক্টর দেখাতে যাই, বেশিরভাগই ট্রান্সফরমেনরা হসপিটালে আমরা ভিজিট করি। হ্যাঁ, হসপিটালে অনেক রকমের লোকেরা থাকে। হ্যাঁ, তো আমি একজন ডক্টর আছে রুবিতে বসে, উনি কেপিসিতে বসেন। তো ওনার কাছে আমি দেখাতে যাই, তো ফার্স্ট প্রবলেম আমার হয়েছিল যে উনি যখন মানে আমাকে সবাই ওখানে ডায়াবেটিক পেশেন্ট ছিল, ঠিক আছে, উনি তো অ্যাকচুয়ালি এন্ডোক্রিনোলজিস্ট। তো উনি আমাকে হরমোন সাজেস্ট করবেন বলে আমি গিয়েছিলাম। তো উনি আমাকে দেখে আমাকে মানে বলছে যে তুমি ছোটবেলার থেকে মানে এইরকম ড্রেস আপ করো, এইরকম মানে এইরকম কোয়েশ্চেন অ্যান্সার কেন, মানে তুমি ছেলেদের মতো, মানে উনি একজন ডক্টর হয়ে উনি আমাকে কোয়েশ্চেন অ্যান্সার এরকম ভাবে করেছেন। ইভেন উনি মানে আরো 4-5টা যখন পেশেন্ট ঢুকেছে, তারাও পর্যন্ত আমাকে দেখে কিরকম একটা বিহেভিয়ার, কিরকম একটা টোনিং, মানে আই কন্ট্যাক্ট ভালো ছিল না, মানে এইগুলো আমাকে সাফার করতে হয়েছে। তো এইটার জন্য মানে একটা ট্রান্সম্যানের জন্য তো আমরা চাইবো যে খুব নমিনাল প্রাইস, একটা ট্রান্সম্যান এমনিতে সমাজের সাথে লড়ছে, তার মধ্যে পারিবারিক একটা সমস্যা থেকে থাকে, মানে আমরা ট্রান্সজেন্ডারদের আমাদের অনেক রকম সমস্যা থেকে থাকে। তো সেটার জন্য একটা হিউজ অ্যামাউন্ট ডাক্তাররা চেয়ে বসে, হিউজ অ্যামাউন্ট। ঠিক আছে, পার ভিজিট মানে অ্যাজ আ ডক্টর হিসেবে পার ভিজিট আমরা মধ্যবিত্ত ফ্যামিলি থেকে বিলং করি, আমাদের কাছে 1500 টাকা পার ভিজিট, মানে রিপোর্ট দেখাতে গেলেও 1500 টাকা, ইভেন নর্মালি করতে গেলেও আমার কাছে 1500 টাকা, এরকম ভাবে মানে চেয়ে থাকে ওরা। তো এই জিনিসগুলো মানে আমাদের একটু প্রাইভেট হলে খুব ভালো হয়, মানে প্রাইভেসি একটু থাকলে খুবই ভালো হয়। তো এটাই হচ্ছে ব্যাপার। শুনতে পাচ্ছ শ্রেয়া?
থ্যাংক ইউ সো মাচ আমাদের সাথে শেয়ার করার জন্য জেডি। হ্যাঁ, আমি শুনতে পাচ্ছি। থ্যাংক ইউ সো মাচ জেডি। আমি একটু ট্রান্সলেট করে শেষ করবো তুমি যেটা এখন বলেছো। থ্যাংক ইউ ভেরি মাচ। Should I translate now, Radhika?
Yeah, it would be great if you could translate now before we go on.
So JD essentially said that he finds that doctors as well as patients behave in discriminatory and harassing ways when he goes to the doctor. And in Calcutta, he says transfer to the hospital where they meet many different kinds of doctors. And he gave an example of going to one private hospital in Calcutta where he met with an endocrinologist to talk about hormone therapy. And other patients were cis patients who were behaving in ways that were extremely discriminatory and made JD very uncomfortable. And the doctor as well asked a lot of intrusive questions about his gender presentation. And JD said that even as a doctor, for the doctor to ask such intrusive questions is not okay. And So JD says that trans men need accessible and affordable healthcare. They are already fighting quite a lot with society as well as family, and he finds that doctors are charging a lot of money when they are going to access healthcare. And even for a very regular sort of health visit, they are charging amounts such as rupees 1500 per visit, which is really very high. And he wants doctor access to healthcare to be both private and affordable for transgender men. Aryan, share with us. Aryan, could
Yes.
you talk about you had spoken about trying to access gender affirmative hormone therapy during lockdown and being told
Yeah.
that it was not an essential service.
Yeah.
Could you please share with us, what happened, whatever extent you're comfortable?
Right. Right. So I had gone to my physician, my local physician. So, and she used to inject me every week. So my injections are every week. And then so when there was lockdown, so there were two doctors sitting. One who is my family doctor, and the other one is her partner, like professional partner. And so when I went there, sometimes when my doctor was not there, the professional partner used to do it. So when I told her that I would need injection, and she was like, "Why are you here?" The partner. So I was like, "It's because my injections are there, and I have to take them every week, no matter what it is." She told me directly on my face that it is not an essential. I'm not even supposed to touch you. Please don't come here next time. And we have given, like, I have had no permissions or no written letter from the government or the municipal corporation to entertain people who take hormones. So it is not an essential product or essential service. So please, you don't come here next time. So that's what it was, and I really panicked because I need to take it every week, and it's difficult to then play with those important hormonal differences if the timings are changed. You can't really play with those timings. And anyways, we have so less research to also take that kind of high risk. So that's the issue that I went through at that time, and it was really irritating. And thankfully I found another doctor then who was like, "It's okay, even if it is pandemic, I will still, you can just come and take the injection." But yeah, this was the local, most of them in the private sector was telling me. And the other doctor who actually agreed to do is my friend's friend. And he was providing his medical service to people in lower income group. So it was easier for him to understand the need, than just saying that it's not an essential need. So yeah, that was one that was very difficult, because I was really unsure what to do. And the best thing that the new doctor did for me, also taught me to self-inject, so that I'm not dependent on the clinics, even after the pandemic. So that's what we need, make if I took injections from him for like 6-7 months. But then later he also told me that sometimes the clinic may not be available, and he was also on the duty of COVID. So sometimes he was not available. So he told me to, let's not take all this risk. And so better what I would do is, you come 2-3 times and self-inject. I will teach you how to inject, and then you can do all of it on your own. So he not only understood my difficulty, but also made me independent and empowered me to self-inject. So I feel that is a kind of service, and that's the kind of thing that we need from medical. That kind of support is what we need from the medical care system. Yeah. Are you able to hear me?
Thank you so much, Aryan,
Yeah.
Aryan and JD. I'd just like to wrap up with, I wish we had more time. I have many more things that I'm sure we could talk about, but I'm being told
Absolutely.
our time's up. But just to illustrate that, our conversations, of course, started with what was happening during the pandemic, because the pandemic was ongoing when we had our conversations. But the fact that this sort of care is denied is obviously the underlying issues are systemic, in that why is a t-shirt not considered essential?
Yeah.
Because it's already a trans exclusionary and insensitive sort of larger system. With that, I'd just like to wrap up, and hopefully we can continue this conversation later.
Thank you, Shreya, JD, and Aryan for sharing about your work and your experiences. And I'm really sorry about the time as well. I really wish we could have a longer conversation, but I'm sure that we could probably continue this discussion towards the end when we're taking questions, and happy to hear more then as well. Something I think that I was really thinking about when, when you were presenting was how often, though we say healthcare, we don't really think of the care aspect of it. We really just think of it as something that is probably ending at giving medicines. But I think what's really coming out from from what everyone is sharing is how much that care aspect is actually missing. And maybe during COVID, the need for that is so much more heightened, and yet we're falling short exactly there. So maybe the new normal that we keep talking about has actually been quite normal for a lot of people all along. And that's something to probably think about as well. So thank you so much for your thought-provoking presentations. So next on panel, we have Kaushal Bodwal, who is a research scholar at the Department of Sociology at the Delhi School of Economics. Kaushal will present a draft paper on the medicalization of the trans community in India and its impact on historical and current forms of policy making. This will include a discussion of the Trans Act and rules, and really looking forward to seeing how we're taking this conversation forward with that, Kaushal. With that, the floor is yours.
Okay, can you guys hear me? Am I audible?
You're audible, perfect.
Okay. So I wrote this paper in the pandemic with CIS, and basically I wanted to do something very different with the paper in terms of trying to transgender, or as I have mentioned, trans in the brackets if you read my paper, the essay, or majorly around gender, that what is the gaze through which any kind of gender, which is not, say, the major binary gender, male or female, when they enters the hospital or when they enters the medical institution, what is that looking basically, and how then that looking gets translated, transcribed into the, the paperwork which happens, and then from paperwork to the major clinic where that particular body is also experiencing the medical professional, the doctor more so. But that was not possible. So this paper majorly is trying to deal then again with the question which has been the question of feminist, radical feminist literature, that how do you do this radical feminist politics when constitutionality has been established. So because, say, we have Constitution of India, and we also have then right now in front of us a very majoritarian passed this bill, which is Transgender Act, which has become, and how is then that act now is establishing certain let's say, I have called it technologies, but certain axes through which you understand what are the different kinds of gender which exist, which exist apart from the binary gender of male and female. So how do you do then that particular kind of politics? And what we realized, and which was also one of the major critique of Transgender Act which came up, was that the act was written from the gaze of a of a binary perspective, that gender has to be in binary. One has to have certain kinds of alignments within the body, including the medical alignments, not just the social appearances, and other has to be very distinct from that particular person. So like therefore we have male and female, and therefore various different kinds of knowledge which we have about these two people. And the initial bill which was introduced in the parliament, I think which was 2016 transgender bill, which had a very blatant definition. They didn't even work to even move a little from towards the sensibility of writing a bill for someone who have always been criminals in the law of this particular land, even into the colonial epithets of whatever law which were there for this particular land. So what they did, they started the definition of transgender is that one who is not these two, but who can also be, who is a mixture of these two. Now the problem with these kind of statements is not just that they are horribly written statements, is also that these displays what kind of knowledge system parliament wants to create of transgenders in India. And it's not that these kind of knowledge have not been there in the social. They are very much there in the social, and therefore they are going to the parliament because, and this is happening after Nalsa judgment, which was a very good judgment. If you look at it, it one thing which Nalsa gives you is that it provides for an evolving category of transgenderhood. So the personhood of transgender can be claimed and not like, I don't know, like not like categorized, or like categorized through pathologization or various other modes, various other technologies. So one of the things which is this particular mode of operation of the social, that there has to be these particular major foundations of gender, which are male and female. Rest all has to be the mixture of it. So at this particular kind of thing which I found, and that is more related to the politics, and I'm strictly asked not to speak about that, but majorly on the welfare part of it. But I'm always skeptical about the welfare part, because the thing is, uh, there are certain the epistemology through which medical sciences knows what they know. Especially I'm not talking about physics per se right now, yeah, but like particularly biomedical sciences, the way they know what they know has always has also been changing. And right now what is happening that uh, okay, so right now what is happening, that the present day narratives of of how you tell that you are sick has changed. So right now everything of in a postmodern has a contribution to your sickness. So basically, if you, so that is why there are certain formations within these particular whatever bordered lands of biomedical sciences, that they are recognizing certain things, that they are seeing that okay, trans personhood has been recognized per se, or say the gay studies have been recognized per se. But the major problem with all these things is that whatever they are trying to do is consolidating that entire thing into an identity, which I think is which I think is something, the moment things get consolidated into an identity, law feeds on that, and that is what law wants. So it's a very compacted circuit of medical sciences that they are producing a certain kind of a mold in which you will only know about these categories of gender through them, through that particular. So they will lay down the foundations. How will you know the knowledge about say transgender or intersex, and then the state will feed on to that particular knowledge and will try to create then these bodies which are otherwise also say maybe absent in the real, but not taking that particular exaggerated position of that they are absent in the real. But one thing which I also encountered in the paper is that there is a distinction between the need and the desire. So the need right now, which I feel particularly, is that everyone should have a right to self-identification. But then again, like these are these are domains which have been challenged politically, because if you're a citizen, then what does it mean to be self-identify? Then you can argue that then these populations must have civil rights, must have, again, everything what has been said by the previous speakers about rights, about accessibility to the hospitals, about and I'm also like waiting for the pandemic to go, and so that I can also find out what a doctor thinks. But some of the instances which are very key to the research, which are also not new, which I would say, are that there is a so medical sciences, at least till now, till 2000, has a policy of looking inside the body to find out what's the problem. So post germ theory, we found out, oh, germs enter the body and therefore like we get sick. So and therefore like the entire genetic research which has happened over till at least 2002 till Human Genome Project has been done to look inside the body, and therefore at certain points, there are these when Human Genome Project was getting made, one of the professors who happened to be from Punjab Haryana border, Hargobind Singh Khurana, he had made the statement that one should always match this particular profiling of genes and not the kundali before marriage, which states, which has a lot of things to say basically. But one of the things which I think is very important with regard to personhood is 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 that it fixes certain things, that the subjectivity of a person, which otherwise would have been under the process of evolution, and evolution not very, I don't know, very Darwinian, because Darwinian must agree to this particular plan of genes stating whatever you do, but uh, but it discourages the process of evolving, of not fixating yourself toward a particular identity, and 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 takes you out of the ecosystem and creates you in some sort of an isolation. So even though it has been claimed that all these social relations through which you know that a person is transgender, but those social relations are the bigger are the only things, especially in the Transgender Act 2019, which are under attack right now. So particularly because I think the law has also been written down from the perspective of making welfare schemes from, but majorly Hijra community, and the one thing which they did not, or chose not to understand, is that family has the unit of household has also been very violent to these bodies, and therefore introduced randomly this one thing to secure the household, obviously, that if a child has been abused by the parents, they would be transferred to the rehab center.
Kaushal, sorry for interrupting you. You have about half a minute left, so it would be great.
Yeah, I'm just finishing.
Thank you.
So these tropes of sending it to rehab center is basically, I'm saying, giving just one example, is killing the relationship which they otherwise make with the gharana system, with the entire system of that, putting the wreath, of all the ritualistic, of all the kinship, of all the following of the religion. Everything has been sidelined to just protect the family. So these are the things basically which were with my concern, particularly when it comes to transgender. Otherwise, whatever has been needed, and the need is of civil rights and of political rights, and the desires, whatever has been the desires, they should be accessible. But the point is, how do you remove from the state's gaze the gendered, I don't know, whatever the gendered lenses which have been very fixative over the period of this, till since the constitutionality and other things, the state is getting fixed, and they are getting established to very fundamental cores of human sciences, if you want to say. But how do you remove that? And this will also be then the problem to the women's movement. But it is high time that they should also realize this particular thing, that by virtue of making it sound like a welfare policy, what state does is that it fixates the gender onto the bodies, and it also then criminalizes other ways of being. even if you want to identify with the same gender which has been getting fixated, but there will be always more authentic transgender sense. So Lakshmi Tripathi becomes the more authentic transgender in India than all the other transgenders who were on streets protesting against this particular bill, right? So I'm saying, therefore, we need to then understand that the politics and the law and the welfare and everything, the discourses of rights, of getting health access and everything, has to come from a very, if I can say, a degendered perspective. So these technologies of gender, which are otherwise getting add on to your being, because if you look at the definition, it's fantastic definition.
Kaushal, really sorry to disturb you again, but it would be great if
Yeah.
you could wrap up so we could have.
But I'll just finish it. But that very fantastic definitions has all these loopholes, which then state has deployed to basically trap you, basically trap the gender, and then fixate it in certain ways that there will always be some genders which will be lesser transgender than the transgender self, which state has produced with the help of medical sciences and using all the social technologies of transgender. Okay, thank you.
Thank you so much for your presentation, Kaushal. We've been discussing the Trans Act from the beginning of to see how the conversation has become more nuanced, more deeper on certain aspects of it as we're going ahead. And thank you so much for bringing out all of these insights. And really sorry once again for not being able to listen to this longer. I really look forward to reading your work sometime soon.
Thank you so much.
So we'll move on to the next panelist now. Our next panelist is Ambika Tandon, who is a senior policy officer at the Center for Internet and Society, and she works at the intersection of gender and technology. Today, Ambika will be discussing her draft paper on accessing maternity benefits in abortion, discussing exclusionary systems in public health hospitals with specific reference to violations of informational and physical privacy. Onto your presentation, Ambika. We can't hear you.
Can't hear you.
Am I audible now?
Yeah.
Yeah, I had said that I'm going to be very prosaic after Kaushal and no one laughed. So I thought I might not be audible. But I will be presenting my work on privacy and reproductive health that I had conducted earlier this year. So these findings are pre-COVID. And my focus, so I'll quickly go over the research question of the study, was on whether women are able to retain their right to privacy, or does it act as a sort of trade-off while accessing reproductive health services, particularly at public health institutions. And here I understand the right to privacy as including aspects of physical and informational privacy, which includes the rights and control over data about your reproductive health. But overall, I'll also be looking at the impact of these on the ability of women, particularly from low-income communities who tend to access public health institutions, on their ability to exercise decision-making and retain control over their bodies. So while, of course, these are individual rights, and often women in this country do not have are not empowered to sort of exercise control over the decision making about their body. But here we'll be looking at how the actions of state functionaries and public institutions are limiting the exercise of this right. So I focused on two aspects of reproductive health for the study in particular. So one was abortion, and this was largely because abortion has become the focus of the policy imperative of curtailing gender biased sex selection, because of which there is a lot of surveillance of women's bodies through a particular lawmaking around gender biased sex selection. And the second is maternity benefits, because as part of a focus on welfare, conditional cash transfer programs, including those related to maternity, these have become the sort of center through which large digital identity programs all over the world, and in India, of course, the Aadhaar, have been implemented. So I'll be focusing on those two aspects. So for the study, I conducted 24 in-depth interviews between January to March this year in Delhi, and these were across a mix of public and private hospitals, as well as some private clinics. Most of my interviews were with women patients and their families, so some were also with providers, including doctors and nurses. So I'll go straight into my findings for the right to privacy when it relates to abortion. So I'm sure, as those working on these issues are aware, physical privacy tends to be a luxury in underfunded public hospitals for women who are accessing any kind of reproductive health services. And but what this particularly pointed to for the purposes of this study was the stigma around services like abortion. So one of my respondents said that the doctor asked her in a room full of men, "How could you get pregnant without realizing it? Now you are asking for abortion. This is very irresponsible." And she said that she was very embarrassed by these kinds of experiences. So I found that such experiences of shaming and stigma were very common, and they impacted the ability of women to access reproductive health in a dignified manner. And this extended to, in one case, a woman going through an experience of beating on her thighs during a procedure as a mode of shaming her. So there were also violations of bodily autonomy through local practices of granting abortions. So the Medical Termination of Pregnancy Act places decision-making power for granting abortions in the hands of medical practitioners, such that they are allowed to refuse abortions, including through the latest amendment earlier this year. So the procedure to grant abortions, I found, was different across the public facilities that I visited, especially for single women. So since they tend to carry some of the stigma around abortion. So at one hospital, the staff dictated that all unmarried women seeking abortions have to report to the police to verify that the intercourse was consensual. At another public hospital, the staff stated that they perform abortions for unmarried women, but they ask them first if they want to file the medico-legal case or they want to go to the police. So they only do this when they, quote unquote, say, think that she looks like she has an understanding of what she's doing or she's working. In cases where they feel like the woman knows, quote unquote, knows what she's doing, then they will not file a medico-legal case. But in all other cases, for instance, for women who may not be working women, they will necessarily go to the police and ask for a declaration of the sexual intercourse being consensual. So I found that a lot of places associate risk with granting abortions to single women. So across these various experiences of having to sign declarations, dealing with the police, etc., these can of course be harrowing and can deter women from seeking abortions due to the moral policing attached to these actions and the surveillance of their bodies. And in particular for adolescent girls, I found that they do not get a chance to exercise their privacy at all, as all underage sex in India is illegal under the POCSO Act. So the police and parents necessarily end up getting involved in these procedures, even if the girls do not consent to this. So a doctor said explicitly that very few adolescents would consider coming to public institutions to seek abortions. And finally, of course, something that has been mentioned through some of the other work as well, the Aadhaar has become de facto mandatory for accessing an abortion in Delhi because of the Preconception and Prenatal Diagnostic Techniques Act, which basically regulates ultrasounds that are needed for abortions. And while the PCP NDT mandates submission of some form of ID, this has de facto become the Aadhaar in Delhi, and a doctor told me on the condition of maintaining anonymity that lawmakers have stopped us from finding a safe and open environment for patients where they can get abortions without fear. They have made people afraid. So she quoted several instances of people leaving her facility, especially if they were unmarried or they were trying to hide the abortion from members of their family upon being asked for identification. So I'll move on to the final set of findings about maternity benefits, where also we see that the Aadhaar has become de facto mandatory. And while we see this in other welfare benefits as well, maternity benefits are an interesting case study because to look at the Janani Suraksha Yojana, for example, to register themselves in the JSY, women need to submit a certificate indicating their below poverty line status or scheduled caste or scheduled tribe status, as well as a passbook for an Aadhaar seeded bank account, proof of institutional delivery from a hospital, and a photocopy of the Aadhaar card. So these are quite cumbersome. This is quite a cumbersome process. And I found that this continues to be the practice despite a ruling by the Delhi High Court directing the government not to insist on the Aadhaar or bank passbooks for providing the JSY benefits on the basis that the JSY policy framework does not explicitly state such requirements because it was pre-Aadhaar. But the Pradhan Mantri Matritva Vandana Yojana, which has come after the JSY, has actually included this in the guideline itself, that you need to submit your Aadhaar card for both set of parents. And for the third installment of the PMMVY, 2 minutes. Okay.
2 minutes.
Yeah. For the third installment of the PMMVY, you necessarily need the Aadhaar details of the husband because they are trying to keep the PMMVY available only for the first delivery of each couple. So this provision then automatically excludes single, divorced, widowed women, as the scheme does not perceive them to be eligible beneficiaries at all. And I'll end on, I'll quickly talk about some of the challenges that women were facing while accessing identification documents. So several respondents had to pay a bribe ranging from 500 to 2,000 to get access to any of the ID documents, including the Aadhaar. Another common complaint was that there was difficulty in registration and updation due to the absence of a grievance redressal system. Some had to wait in line to get appointments from 7 a.m. and they were waiting for 4 to 5 hours before they could even get a token. So this was very difficult for women because they had caregiving responsibilities, due to which they had given up entirely, and they were reliant completely on their husband's ID while trying to get access to both the benefits and the services at public health institutions. And the final point I wanted to make was about the sort of layers of information gaps and information asymmetry that existed between patients and institutions. So many of the people that I spoke to were completely unaware of the existence of such schemes, even if they were eligible. Some had no idea why they were asked for additional documentation like voter identification and additional address proof as well. And no one that I spoke to was aware about what happens to their data or their identification documents, their photocopies, what happens to it once they actually submit it. They did not know about health information systems such as the mother and child tracking system, which creates a centralized profile of all reproductive health beneficiaries in the country. So this can, of course, become an impediment in grievance redressal, but it also makes the possibility of informed consent while collecting this data completely impossible. And this is going to become more of an issue given the kind of recent announcements that we've seen this year, such as the health identification, health ID that was recently announced by the Prime Minister. So that has a very complex imagination of a consent architecture, which will allow patients to share their data partially or fully with providers, exercise rights such as opting out of databases, etc., which sounds great on paper, but we have evidence of the fact that it's not going to work given the fact that there's a large information asymmetry when it comes to the beneficiaries themselves. Yeah, I'll stop there.
Great. Thank you so much. Thank you so much for your presentation, and that sounded harrowing. I'm so worried about what would happen if one were to actually require any of these. By one, I mean if I were to actually require any of these services, especially during COVID. And now we're also hearing a lot of cases where you know, people have died because they were not admitted to hospitals because they could not furnish their Aadhaar cards on time when they went to multiple hospitals, and they were just not admitted because of lack of valid identification. So, and of course, a lot of these problems, as you said, are compounded because of gender. Thank you so much for carrying out this study, and really looking forward to reading your paper once it's out. Good luck with that. So we are going to now move on to our final presentation for the day. We will be taking questions after this presentation, and we'll be discussing the questions. So for for everyone in the audience, if you have questions to any of the speakers, or even if you just have general questions to the entire panel, please do drop them in the chat, and we'll queue them for the end. So you can go ahead and start doing that right away. And with that, I will invite our final speaker for today's event, who is Rosamma Thomas. Rosamma is a freelance journalist based in Pune, and will be presenting her work on the barriers to AIT treatments and insurance for people living with HIV, including the impact of linking Aadhaar, the challenges around data ownership and violations of privacy, and just in general about the ubiquity of Aadhaar that we seem to be hearing so much about and are very validly worried about. Rosamma, the floor is yours.
Yeah, thanks. So this direction that Aadhaar is necessary for HIV treatment, it was first issued in 2017. And immediately after that, on Scroll and other websites, there were reports about people dropping out of treatment for fear of violation of their privacy. And I started my study in Bangalore, and practically everyone I spoke to there was concerned about privacy. So one of the people I interviewed was a software professional, 47 years old, gay, and had been diagnosed HIV positive 2 years before I met him. So he said that he had to go through a surgery, and the expenses would have been reimbursed by his office. But he didn't want the papers to go directly from the hospital to the office. So he made sure that the payment was taken care of, and then he only produced bills back in the office, because otherwise they would see all his papers and the office would get to know that he was HIV positive. Then there were people who were accessing treatment at the government facility in Victoria Hospital in Bangalore, one young man who was a researcher, he said everything could just be lying around. The registers with their names and phone numbers, all of that could be easily accessible. So he said he stopped going to the government facility and then found a private institute to kind of go to for his treatment. And what is good about Bangalore is that there is this one private facility where a lot of them seem to be, it's like a community. They know each other, they come and discuss problems. So when I went there, the doctor just called a couple of patients together. I interacted with some of them. So it seemed like that was one small community which was like supporting each other. And even in terms of even for advocating for their rights, you know, they're not under any insurance scheme. Technically, under law, they're not supposed to be discriminated against, even if they are HIV positive, for provision of health insurance. But on the ground, that is not the case at all, because the law itself provides for actuarial reasons for exclusion of insurance, and this is used routinely to deny them insurance. So what happens is a lot of them cannot even then speak for themselves, because even to raise it would be to betray your HIV positive status more widely. So they don't talk about it. There's only one one person I know of in Chennai, someone called Daisy David, who's been HIV positive for long and who doesn't mind reporters using her name, and she's happy to be quoted by name. But all of the others just don't like. So there's no way that they can even assert their own rights themselves. So after doing my research, it just occurred to me that this kind of then Atmanirbharta doesn't work. You can't be self-sufficient. They are dependent on the wider community to take up their causes and to for solidarity. And in Bombay, I was when the lockdown came into effect, a lot of them could not then access their medicines. And what was happening was that HIV positive people were themselves getting together and seeing that, the medicine supplies were regular, and they were, going around on scooters and giving people their medicines and all of that. So within the community of the HIV positive, there is already a solidarity. But I think to protect their rights, there is need for that to extend to the wider community. Even people who are not HIV positive should be looking at issues like their, access to insurance. And in any case, I think provision of healthcare through insurance is a failure. I was just reading recently about how healthcare in the US is so expensive, and despite that, life expectancy is not as long as in Australia, which doesn't rely so much on insurance. So a lot of what I had to say and what I planned to say has already been covered by Brinda. So I will just, I think, I can even end it here.
Thank you so much, Rosama, for your presentation. And Ayush has also linked some of Rosama's work in the chat for those of you who would be interested in reading it further. So please do go and check that out as well. So we have some time to take questions right now. And we have some questions, I think, okay. Ambika has already proactively responded to the question directed at her on the chat. So I'm going to leave that for now. There was one question earlier for Brinda, which says, what is the new law which will create inclusion? I think, Brinda, this was in the context of your work. This question's by Millie. If you need any clarifications, we could check. Brinda, would you like to take that up, or would you?
Can you hear me now?
Yeah.
Okay. I think the only law that I mentioned was the Transgender Persons Protection of Rights Act. And to be honest, I was being politically correct or polite when I said, if things are implemented, then there will be inclusion. But the kind of data challenges per se that exists, it's going to only amplify it further. It's not likely to reduce that at all. So that's the only law that I mentioned. And that's it's not likely to create inclusion.
Thank you so much, Brinda. We had another question that was actually directed at Aryan, but I think they've left the chat, or am I wrong? Do we still have Aryan on the?
No, I think I in the middle. If I could, I just wanted to add one thing. After completing my my paper, I've just been continuing to read on the issue, and I am surprised by the huge gap between the talk at the policy level and the reality at the ground level. So yesterday's Hindu, for instance, had a report on how Narega workers are having to spend a third of their weekly wages just trying to retrieve their money from the bank. They're traveling to the bank, which might be some way off, commuting cost of not working for that one day when they need to go to the bank. All of that put together is a third of their weekly wages. And today's Hindu carries a report where the Prime Minister was addressing some meeting virtually, and some work is being planned in collaboration with Australia for cyber security and a whole host of digital technology initiatives. And he says that digital technology has become a reality in rural homes in India. So somewhere there's this huge gap between what we know is the reality on the ground and what the policy speak is. And I don't know how this is going to be bridged, because there is no, no matter what you figure out at empirically, it doesn't seem to register at policy level or even with the court. Even when the Aadhaar matter was in court, so much evidence was presented, but it was just not taken up. So I don't know, when it comes to policy, advocacy, I don't know what then we should be doing.
Thank you so much for sharing that, Rosamma. I also think to some extent, I was thinking that we also, people who work in policy and law often are very sort of distant from the grassroots realities. And I think that distance sometimes translates to the kinds of policies that we see and the issues that we see around them. So thanks for bringing that up. Okay, Ayush has posted a question on chat. I'm going to read that out, and any of the panelists can take this up. A constant challenge has been logics of enumeration. However, the solutions often oscillate between better enumeration systems or no enumeration systems. Any thoughts on this binary? Do any panelists in particular want to respond to this?
I'd like to respond if no one's taking that question. I'll wait.
Go ahead, go ahead.
I was just in fact thinking about with the AI policies coming in. So when you look at AI and when you look at, basically my study is a big data study, when you're looking at data being large enough to actually create patterns, right? And when we're talking about specific identities, and I'm not talking just only gender, with any identity, any socially excluded community, whether persons with disabilities or transgender persons. When you look at the entire population, the population is not large enough to actually create patterns. As much as we say, yeah, the system will be fed in with all these exceptions, etc. So far, the way the system is functioning is not very reassuring for us to believe that that's going to really happen. So what will then happen is this: when patterns don't exist, when people beyond the binary are not recognized by data systems, they don't exist as a pattern. They're not considered population group, right? So then when decisions are going to be made based on the data of people in these systems, essentially there will be no services available at all for others, or any minority group for that matter. Solutions policies need to be based on human rights more than based on data. And right now, data is what is being used as the way to drive solutions. But it needs to, and there is no tying up of human rights anywhere. Like Tamil Nadu government has come up with a state AI policy and blockchain policy, and there's no mention of human rights even there. So what are we going to base this on? This is supposed to drive inclusion, but when there's no mention of human rights, how do you drive inclusion? Thank you.
If I may just add a little bit to that. See, when we have Transgender Act, why don't they get transgenders also to contribute, to writing up the law? When we have sanitation workers related laws, why don't we get people from within that community to actually be part of the process? So, these people are just not, now we have a sanitation workers law for which they're only thinking in terms of technology. They're not considering caste at all as part of something that needs to feed into the legislative process. So these exclusions happen because the communities just don't exist in the lawmaking aspect of it.
If I could also add something very quickly. I think one of the issues with enumeration also is, if you look at the sheer diversity of any single there's a lot of conflation of identity and experience. Because what tends to happen when, for example, we look at even something as progressive as NALSA, there isn't enough of a differentiation between intersex person's issues versus trans person's issues. And there are large overlaps, but there are also distinct issues. If you look at the issue of medicalization, for example, there's a very different engagement with the medical establishment, because the fact that very early and non-consensual surgeries are happening on intersex infants in order to make them fit inside the binary, that has a long-term potential impact on the health of the person, which requires a different kind of engagement with the medical fraternity versus, when you say we have the right to self-determined gender identity. So if I say I'm trans, I don't need to go to a doctor. I don't need to go to a psychiatrist. There should be no gatekeepers. Medical gatekeeping is out of the window. So when you're conflating these extremely diverse experiences, and you just kind of, in the politics of enumeration also, when it's happening from such a top-down thing, and we saw in the process of between the NALSA judgment and the Trans Act, which has now been passed, in 2019, the sheer lack of public consultation, and not that trans people weren't talking. There was a very concerted, very comprehensive of when the enumeration is top down. Exactly what Brinda and Rosama pointed out is the logic of that is not going to take into account the diversity of the actual experiences, which becomes really problematic. And in my interviews, we weren't even talking about data. There are so many problems that are like even before that. I mean, of course, we could have gone on to talk about data, and it would have also emerged as something to definitely note. But before that, just even going to the clinic is so difficult for the people that I spoke with. So, then when we talk about enumeration, really, whose enumeration are we talking about?
Thanks to all the panelists for responding to the question. We have time for one final question, and we have a question on chat, and that's open to any panelists. So I'm going to read that out. Flynn Coleman recently wrote a book called A Human Algorithm, in which he argues that technology, especially AI, reflects the same biases that a human experiences or asserts. Is there a future where AI's inclusion in healthcare or health services is beneficial in breaking down barriers to services rather than creating them? Is there any panelists that would like to take this up? We have a couple of minutes before we can conclude.
I can respond very quickly, and then if there's, I see that there are others who unmuted their mic as well. So
maybe you could begin, and then we can continue.
Yeah. I just quickly wanted to say that biases are, an area that have been talked about quite a bit when coming to technologies such as AI. So there are, people have come up with solutions like trying to create data sets that are more representative, which is of course one direction to take this in. But also I think one of the issues is again what has been pointed out in representation, just the fact that the intent of a lot of these systems comes from an urge to centralize, an urge to control, because a lot of the funding structures and the very structural issues around the manner in which these technologies are being deployed is to try and control people's bodies. So I'm sure that there are many ways in which AI and such technologies could help local health providers in enhancing the way that they do their work, but a lot of the decision making isn't actually in the hands of frontline workers. It ends up being in the hands of it's a top down structure of sort of designing these technologies in the first place. Is there anyone else who wanted to respond?
I'd like to add something from a slightly different perspective. In a recent conversation I had with people working on the rights of persons with disabilities, right? They had a look at AI, and their concerns have been about it's also about enhancing the future, right? About probably for a person with disability, the possibility of this technology actually offering them some kind of mobility of any sort, right? For any kind of disability that they may have. having a chip inside their body. So, and that is a point that is being contested. If that is the way ahead and that is the future, then where is our bodily autonomy in that sense? For especially when you're talking about someone with disability who has not experienced it before. How much of who you are as a person is going to be taken away from you is also something we are going to have to consider. And of course, I am not someone who can answer that, as much as what is the agency that is being kept and like taken away from individuals is also something that needs to be really taken into consideration when we're looking at this and answering. It's a very layered, privilege based question also. So we need to, the moment we look at all those privileges, who is responding to this question also then becomes important when we're talking about AI and data based AI solution systems as well. Thanks.
Do we have time for me to add?
Please do add.
Okay, so I think like this question is really interesting. Of we constantly see these sort of almost miraculous technological solutions to what are really social problems, and I'm speaking in the context of all these different engineering solutions to sexual violence, something that beeps or something that bursts or something that happens when you're being attacked. But the issue is when we divorce the idea of design and intent from the use of the technology itself, we're actually talking about a false binary. Technology is always designed with a certain intent. It's just, if we come back to the sort of example of people with disabilities, for someone living with visual impairment, for example, a screen reader is a technology that is giving more accessibility, right, to somebody who has the ability to buy a screen reader, to have that technology. But also at the same time, there are apps that don't follow basic accessibility guidelines. So when they could easily be accessible, the buttons are not labeled and the screen reader can't read them. So, to divorce the question of, is there a technological solution? Sure, like it depends on the design. If you're designing it for the able-bodied cis person who doesn't need, I mean, when your design approach is assuming a neutral user who actually doesn't exist, then to talk about a technological solution in isolation is sort of not really the way to go, in my opinion.
Thanks, Shreya. Are there any other panelists who want to respond to this? If not,
Radhika, I have a suspicion you may want to chime in on the question as well, please. Feel free to do so.
All right. I mean, I think everyone's already given great responses to it, but I just wanted to add that I think this is an example I always give while talking about AI, that there's this saying that if you have a hammer, you will treat everything as a tool. I mean, you'll treat everything as a nail, sorry. And I think that's what we do a lot with AI. We think that AI is like a solution to all the social problems, and that makes us look away from the structural social problems underlying this. So in this question, when, for example, we're looking at barriers to healthcare, often the barriers to healthcare are very structural issues. So for example, we have, and this is something that every AI startup and company will say when they make AI healthcare diagnostics, they will say that we have a lack of doctors in India, and that's why we need to have automated diagnosis, for example. But the question is, why do we have a shortage of doctors in India, right? There's a structural issue there. Like, we have an exorbitant cost of medical college. We have a lot of doctors going into more lucrative fields. There are very few people who would want to work in a PHC. Why are there few people who want to work in a PHC? Because PHCs have, they don't have electricity, but now they have AI there. So there are a lot of very underlying structural problems that we have. And I think AI often distracts us from finding long-term sustainable solutions to them. So in some small ways, definitely technology can improve our lives. But when we look at it as the hammer that's going to sort of be able to, hammer in every single tool without seeing whether that's a solution that AI can even fix in the first place, I think that's where the problem is. So I think constructively, an important question that all engineers should be asking themselves, and I say this as someone who was an engineer myself, is not how can AI solve this question, but can AI solve this question? And then maybe just don't touch it if you think it's not going to make, if it's going to be a problem because of things like biases, etc. Sorry, I felt like I really wanted to chime in and say that because I've done some research on AI myself, but I'm really, I was really excited to hear what everyone had to say. And thank you so much to all the panelists for their great presentations. I learned a lot listening to all of it, and I'm sure all the speakers, all the participants did. I'm really looking forward to reading the papers too. I'm going to hand it over to Ayush now to conclude.
Hey, thanks, Radhika. Yeah, that was certainly up your alley. Yeah, I think we made. Thank you everybody for joining us and for sticking around. We overshot by a few minutes, so thank you for still, being around for the most part. Yeah, as Radhika just said, there's just so much learning to do over here. Even though I've been involved in the project in both of the projects, each time I revisit the writings, have conversations, be a part of these discussions, it just gives more food for thought. It was great to see the appreciation for all of our panelists and for the moderators as well. I want to express my thanks to JD and Aryan as well, who couldn't be around. Shreya, please do convey everybody's gratitude and appreciation for their sharing and for joining us for at least a brief period. With that, perhaps a call to action is that it's important to continue having these discussions, problematizing the developments that are happening around us, and especially in the context of the pandemic, where a lot of these sort of ideas that sort of center technological efficiency are getting intensified, right? So a lot of the problems that were faced with governments responding to the pandemic were posed often as data problems, or as and like surveillance, then epidemiological surveillance, then becoming a sort of very a commonplace name. So I think it's imperative for us to keep having these conversations, continue the research, and as some of the questions highlighted, try to arrive at, try to have some agenda setting meetings that can inform future research and advocacy projects. That's it from us. Thanks again to everybody for joining us, and we'll be sharing some of the materials that we put together as a result of these discussions with you over the next couple of months. Thank you, everybody, and have a great rest of the day. Bye-bye.
Thank you.
Thanks.